We are going to talk about Chapter 10, Assessment of a High-Risk Pregnancy. I do want you to review boxes 10-1, 10-2, and 10-3. These are very important boxes in regards to high-risk factors for pregnancy, and box 10-2 is pregnancy problems and related risk factors. So it talks more in depth about if we have a mom with polyhydramnios, what is causing that, what is the potential cause for that. And there's a few other disorders there that kind of tell you what would cause it. Box 10-3 is common maternal and fetal indications that we would need some type of antepartum testing. Remember, antepartum is the beginning stages of pregnancy. So these are things that we are doing to try to catch any kind of high-risk factors in the beginning so we can manage mom and baby better throughout the pregnancy. One of the most important things you can teach your moms if you're a labor and delivery nurse, if you're working at a clinic where moms come in and they're pregnant, is to teach them how to do a kick count. The correct term for that now is daily fetal movement count, and they write that actually in an acronym DFMC. So that is daily fetal movement count, or also known as a kick count. This can be done at home. It's non-invasive, it's not expensive, it's pretty simple to understand, and all moms should be educated on this, and they should be doing this periodically. We need to know that for moms in the third trimester, babies make 30 gross body movements within each hour, so that's just kind of a little fact, statistics. There are several different protocols that can be taught to your moms on how to do a kick count. One of the recommendations is to count once a day for 60 minutes. The other is to count activity 2 to 3 times a day. We want to make sure that we do this after meals and before bedtime. With babies, they do sleep during the day. They don't stay awake all day long. So it is periodically that they'll be in sleep patterns. But after mom eats and the baby gets glucose, they're just like us. We go, we have a snack, we're energized, and then we probably doze off and would want to take a nap about 2 hours later. Babies are about the same way. Once mom eats, they get some glucose, they're up and they're running around. Not running, but they're pretty spry. What we're doing is we will count that 2 to 3 times a day after meals before bedtime for 2 hours or until mom feels 10 movements in a 12-hour period each day until there is a minimum of 10 movements that are counted. The picture you're looking at on your screen is a chart. This can be given to mom, and she can actually log the day of the week and the date and how many kicks, and it gives her a little bit of instructions. So this is an important assessment tool that can be given to mom, so she can be doing this at home. The one thing you want to stress to mom is that if she has a count of less than 3 fetal movements in an hour, she needs to come into labor and delivery, and she needs to have an evaluation done, whether it be ultrasound or exam or something needs to be checked. This is a picture of a ultrasound. What you're looking at is from your textbook. They have the ability to do 2D, 3D, and 4D ultrasounds. These are 3D that you're looking at. A lot of technology over the years, and the pictures that come across in ultrasounds of babies are amazing, of how this 3D image looks exactly like the baby when the baby is born. So there's a box on 10-4 that just tells you the different types of ultrasound and kind of gives you some information about it. That's just kind of more so that you're aware of it for educational purposes. The one thing you need to know is that ultrasounds, and you should remember this from NUR 226, can be done transvaginally or abdominally. The major uses, or why we would actually use a ultrasound or need to have an ultrasound done, goes back to that box 10-1 with the high risk factors for mom. One of the things that we can do when they're doing an ultrasound is we can actually look at fetal heart activity. We can do this as early as 6 weeks. It has to be a transvaginal ultrasound in order to determine that. The other thing that we will look at in the second and third trimester is we're actually looking at fetal presentation. That plays an important key into the delivery and the birth of the baby. We can look at amniotic fluid volume, cardiac activity, placental position. We can also look at baby's growth patterns and number of fetuses if we have a mom who's in and she has multiples. When we would be using an ultrasound in the first trimester, we're getting things like the number, the size, and the actual location of the gestational sacs. We would also be able to note if there is an absence or presence of fetal cardiac and body movements. They can also look at pregnancy dating. So if we have a mom who comes in and she's not really clear about her last menstrual period, but she's pregnant and she's not really sure, how many weeks, they can also use this as a tool to try to get a better guesstimate of how many weeks mom is. The other thing I want to talk to you about is the term IUGR. I had mentioned this back in one of the other slides and podcast, and it's one of those that's going to keep popping up as we go on. But I'm going to define it a little bit better for you. IUGR is intrauterine growth restriction. It can be defined into 2 categories, symmetrical or asymmetrical. If baby has IUGR and it's symmetrical, this means that the baby is just small all the way around in all parameters, aspect, head and body. If the baby is asymmetrical IUGR, the head and the body don't match. Typically the head's bigger and the body is smaller. So that's just a little bit more definition of IUGR and how they can break it down to 2 other subcategories. The picture that you are looking at is from your textbook. It is a picture of a nuchal translucency test, also known as an NT. And that is nuchal translucency test. The purpose of this test is we're actually using ultrasound measurements of fluid, and we're looking at the nape of the neck. So right here is where we're looking in relation to the actual nasal bone. We're trying to identify fetal abnormalities. They are assessing fluid in the nuchal translucency test. So right here where it says NT and I have circled it, that's where they're looking and they're obtaining a measurement on ultrasound of fluid. They obtain that measurement, and then what happens is if there is a greater than 3 millimeter amount of fluid, this is considered abnormal. They will combine this with maternal serum marker levels that are drawn for mom, and if they are low, then what that possibly means is there's an increased risk for chromosome abnormality. The ones that they're thinking, or the ones that they would be identifying in the nuchal translucency test, is your trisomy 13, 18, and 21. Now, if they have an elevated nuchal translucency test and mom's markers are normal, then what they're considering is it's actually a fetal cardiac disorder that could be going on. What you're looking at is a picture from your textbook of the Doppler blood flow analysis. Before we talk about this, there's just another thing that I want to talk about in regards to the placenta. Some of the things that you need to know is the placenta is clearly defined on ultrasound between 14 to 16 weeks. If the placenta is seen low-lying, and when I say low-lying, that means the placenta is over the cervical os. So that would be a low placenta. It's not off to the side. What they are going to do is in the second trimester evaluate, and then if that placenta is still there, it is possible that mom has a placenta previa. we will talk about placenta previa again, more in depth down the line. They will diagnose this in the second trimester, but for most cases, if this is diagnosed in the second trimester of placenta previa, low-lying, it's usually resolved by the term, so it's usually resolved by 40 weeks. Mom will still need to continually get ultrasounds to monitor that placenta to make sure it is resolved. The reason it resolves, if you see it in the second trimester, is because of the stretch in that actual uterus. The other thing you can do with ultrasound is actually look at the placental age. We're looking at calcium and fibrin deposits in regards to the relationship to age of a placenta. When we talk about postpartum babies who are after 42 weeks, postpartum babies after 40 weeks, the placenta starts to calcify and shrivel up. And we know that the placenta is very important for oxygen transport, so that has detrimental effects on baby. And we'll also talk about postpartum babies too later on. So now let's talk about a Doppler flow analysis. What you're seeing is reflected sound waves. It's reflected because there's a moving target and there's a change in the actual frequency. This is also called a Doppler effect. What happens is you have a shift in the frequencies and it plots a velocity versus time. Now, don't get so hung up on that terminology, but that's the picture that you're looking at the right. You're looking at sound waves based on movement, and they look like teardrops. So kind of think of it as you want to see some type of a movement, so you want to see a bounced wave. One of the things they also can do is that they're looking at 15 weeks gestation, they're looking at a SD ratio, systolic over diastolic ratio. This is taken from the umbilical and the artery veins, and that's the picture on the left that you see lit up in red and blue. They're obtaining a ratio. All the numbers are configured from the ultrasound, and if it's above 3, then there's some type of a placental vascular disease going on. The other time that they will do this particular test is when we're talking about post-term babies, and there will be an elevation in the SD ratio, and that means there's a poorly perfused placenta. Remember, I just talked about the placenta as the weeks go on longer past 40 weeks, the placenta calcifies and perfusion becomes less and less. The other thing they can look at or obtain from these measurements is chromosome abnormalities, and that would be your trisomy 13 and 18. So it's a Doppler flow analysis. It is based on movement and bouncing off of sound waves. So you want to see some type of a sound wave. You want to see a peak or a mountain. You do not want to see a low little hill compared to a mountain. You're seeing on the left, they're looking at the actual blood flow of the vein and artery from the umbilicus. So that's the kind of thing I want you to take from this particular test. Okay, what we are looking at now is a picture of an amniocentesis. You can see the picture on the right where mom is actually having an amniocentesis done. This is a needle that is injected into the amniotic fluid space. They draw out fluid and then they test it for different components. The components that are tested from amniotic fluid is on table 10-4. They look at the lung profile. Remember, we discussed an LS ratio. That's telling us about fetal lung maturity. There are some other components because these are proteins and enzymes that they can also look at to assess fetal lung maturity. We're also looking at something that we're going to talk about in a few slides, alpha theta protein. That's important. So there's a combination of different things that they're actually looking at from the amniotic fluid. What we need to know is there are some complications that could occur. In regarding to mom, those complications could be leakage of amniotic fluid, hemorrhage. There could also be that possible RH isoimmunization infection. Remember, if we have a RH negative mom and a positive baby, they're mixing blood and they don't like that. They want to reject it to each other. So if mom is getting an amniocentesis and she is RH negative, she's going to get a dose of RhoGAM at this time. Things that can happen with baby: death, hemorrhage, infection, and direct injury from the actual needle itself. When do we want to do an amniocentesis? When is the higher indications for this? Moms who are over 35, moms who've had a previous child with some kind of a chromosome abnormality or a family history, and anytime mom herself has had any inherited metabolism disorders. One of the examples is Tay-Sachs disease. Tay-Sachs disease, if a baby is positive for Tay-Sachs disease, their life expectancy is not very long. Hemophilia is another one that you would indicate that we would do an amniocentesis. The other thing you can obtain from the amniocentesis is that measurement where we're looking at the actual amniotic fluid volume. Okay, now what we're going to talk about on this blank slide, because for some reason I left it out on your PowerPoint, but it's extremely important because we have to assess baby's well-being. There are two ways that baby well-being is assessed, and you will see it constantly. When we are assessing mom and she's coming in for appointments, we are going to assess baby in these two ways. The two ways are a non-stress test, which is an NST, and a BPP. This is a biophysical profile. This is the one we're going to talk about first. If you look at table 10-2 and 10-3 on page 257, there is the breakdown of what is in a BPP. Nurses can do this. They assess a score. You either get a 0 or a 2, and then you are tallied up a number, and that tells you what is going on with baby. So first let's talk about what is included in the BPP. We are looking at fetal breathing movements, and that is abbreviated FBM. If baby has one episode of fetal breathing at least 30 seconds, at a 30-second duration in a 30-minute observation. So baby takes one breath for at least 30 seconds in a 30-minute observation, they get 2 points. If the baby has no fetal breathing movements, or it's less than 30 seconds in a 30-minute period, they get a score of 0. Fetal movement, which is FM, is the second component of the biophysical profile. There are 5 components total that make this up. So for fetal movements, you want to see at least 3 trunk or limb movements in 30 minutes. So babies either kicking their legs around, their arms, or their bodies shifting around. If baby has less than 3 in 30 minutes, they get a 0. Next is fetal tone. For fetal tone, the baby has to have one episode of active extension with the return of flexion of the limb or the trunk. So baby stretches out and stretches back in. If baby does not have this movement or is very slow on extension or reflection, they're given a 0. Now next is the amniotic fluid index. The amniotic fluid index is actually obtained by ultrasound. It's a fluid measurement. So if baby has, or there's greater than 5 cms or centimeters, and they also talk in terms of pockets, but we're just going to stay with if there's amniotic fluid index and it's greater than 5, they get 2 points. Less than 5 or equal to 5, there's no points. Then the next component to the biophysical profile is the NST. We're going to talk about the NST and what that means and how you determine an NST or interpret it. So what you need to know for the BPP, if it was reactive, they get a 2. If it's non-reactive, they get a 0. So those are the 5 components of the biophysical profile, and they are extremely important. You guys are going to see them again. You'll probably see them again for me, and you will probably see them again on boards, because it is important to assess not only mom, but to assess baby. Now let's interpret the scores. So we've got a baby, they're doing fabulous. On all of these components, all 5, they score a 2, so they have a marker of, or score of 10. So baby's normal, and they're low risk for asphyxia. And that's essentially what we're assessing. We're assessing the environment that baby is in. We want to know that that baby is fine and the baby is not compromised for breathing, and we want to know that they're going to be okay and that they can withstand delivery. But if we have a baby and these markers are not going so great and we only score, let's say, a 4, then it tells you on your table 10-3 that we're suspecting chronic asphyxia. But if we are 4 and this is a greater than or equal to 36-week gestation, you are going to be delivering a baby. If it is less than 32 weeks gestation, you're going to have to repeat the score. Okay? So be familiar with those 2 boxes. So what you guys are looking at is a picture of chronic villi sampling. This is a transcervical method. You can also do an abdominal method of obtaining a sample. The nice thing about this is it can be done earlier than amniocentesis. It is similar to an amniocentesis as far as what information it is gathering. It can be done between 10 to 13 weeks gestation. No fluid is obtained, and it's actually reflecting the genetics of the fetus, not just getting mom samples also.